Hello, I'm Patrick Nelli, the president of Health Catalyst. Ashley Shearer, similar to some others, unfortunately had COVID exposure, so she cannot be here. She is the director of care coordination at Queens. Her and the team did all of the work on this initiative, but I'll do my best to try to present in their place. So the problem that we're talking about here today is one that is familiar to a lot of us, in the sense that we all know that a small portion of the population utilizes a disproportionate amount of the care that's being provided in the U.S. healthcare system. This initiative focused on that, and in particular, focused in on ER superutilizers, and even more specific to that, focused in on homeless individuals as ER superutilizers. At Queens, which is a healthcare system in Hawaii, homeless individuals made up 60% of all ED visits for Queens. Hawaii also has the second highest homeless rate per capita of any state. That said, this is a problem that is relevant nationwide. Homeless individuals visit the ED at a rate of approximately 5 times patients that are not homeless. So what was this initiative? Queens partnered with a local Medicaid managed care organization to fund 4 healthcare workers initially in the initial pilot that would focus on providing very high touch care to these initially homeless ED superutilizers. The high touch care was a 90-day plan where these healthcare workers would help initially homeless individuals try to find social services and community health support, try to help them find more permanent housing, take them to relevant medical appointments, meet them in parks, meet them on sidewalks, meet them at their shelters, to really do anything they could to help get these individuals the appropriate medical care and help them get the appropriate support services in their community. The other important aspect of this initiative was Queens sharing information with now a broad set of payers, but initially the first Medicaid managed care health plan that partnered with Queens. So they looked at socioeconomic data, claims data, clinical information, and the like to do 2 things. One, to help prioritize which patients to first focus on as part of this program, and 2, to look at the efficacy of various interventions that were occurring by these healthcare workers, and which of these led to statistically significant improvements so that these healthcare workers could focus their time there. Some of the lessons learned included keeping the caseload relatively small per healthcare worker at 10 or fewer patients at any point in time. As I mentioned before, it was important to use data both to identify root causes, and also as the program increased and got larger, it was important to make the data and analytics available to these leaders of this program so that they could use it in a self-service manner to understand what interventions were leading to the most statistically significant improvements, so that this program could iterate quickly and build upon itself. It was also very important for these healthcare workers to build rapport with these patients. So they would first meet them at the healthcare facility, but many of the multiple times a week they would meet them for the next 90 days would be outside the healthcare facility. As I mentioned before, in parks, shelters, they would try to meet the patients where they were at. And there were not requirements for these patients, not strict requirements for these patients to be enrolled in the program, in the sense that if these patients missed an appointment, they continued to be enrolled in the program. If these patients continued to use drugs, they were continued to be enrolled in the program. So it really was trying to meet these patients where they were at and find them support through community health and local social services. these are the results in SPC charts, since we do like statistically significant data at Health Catalyst. So what you can see is approximately a 70%, just under a 70% relative reduction in the number of patient hospitalized days. A larger than 40% relative reduction in readmission rates, 1,400 fewer ED visits, 700 fewer ambulance transports. This equates to approximately $16 million in cost avoided. And importantly, more than 60% of patients who were homeless at the beginning of program enrollment had secure housing by the end of the 90 days. And while I do love data, there are individual patient stories that make this project really meaningful. There was an individual who was homeless, living in a parking lot for 10 years prior to enrolling in this program. He had substance abuse, mental health issues. In the 3 months prior to starting this program, he had gone to the ED 16 times, been hospitalized 4 of those 16 times. When enrolled in the program, the healthcare workers first helped him find medical respite bed to support him overnight, then helped him get access to various social services, including food stamps, including Social Security, then helped the individual go shopping, go to the grocery store with that individual, taught him how to cook, obtained permanent housing for him at the end of the 90-day program. And 2 years since that initial pilot, that individual is in permanent housing and has not been to the ED since. So stories like that always make me, and I think should make us all proud for the work we do to try to better connect payers and providers. And I think I have a couple minutes for questions. For sure. When they're in the program, oh, thank you. I didn't know how to go back. So when they're in the program, it is a fairly manual data tracking process when they're actually in it, in the sense that the healthcare workers are collecting social determinants of health information. They're inputting that into a system, but they are the ones collecting this more detailed information. And that information that it was tracked, as well as the interventions that the healthcare workers provided, ended up being very important indicators to determine what would lead to the best outcomes. So there's a lot of manual social determinants of health, as well as manually tracking what interventions were done for these patients. Yeah, for sure. So initially, it was a small pilot. So it was not a comprehensive initiative across healthcare systems, across payers. So initially, the data, to your point, it was only as good as the data available, which did also include HIE information. So that, in addition to claims, could help broaden it beyond just one system, but it was still not perfect. The program has since expanded, and there's more data sharing between payers and other providers going on. So that is helping that problem you mentioned, but it's not perfectly solved yet. Yeah, no problem. Oh. And I think I'm over time. Thank you.